Good morning. I'm Martina Andellini. I'm a biomedical engineer and I am a PhD student at the University of Warwick. This work was carried out during the first wave of COVID in collaboration between the University of Warwick and Bambino Gesù Children's Hospital in Italy. The work I'm going to present is an evidence-based comparison of the clinical needs and the technical requirements for ventilators for COVID-19 treatment of critical patients. From December 2019, when COVID-19 was identified for the first time in China, it caused more than 3 million deaths and 173 million confirmed cases worldwide. And considering the Italian situation at March 2020, in Italy, there was the availability of 590 intensive care unit beds. And during the first wave, a significant number of COVID-19 patients presented acute respiratory failure, demanding for each intensive care unit admission. It occurred a sudden increase of intensive care unit bed demand, and it was registered an increase of intensive care unit length of stay compared to the duration of stay for patients with community-acquired pneumonia and influenza season. And in order to deal with the unexpected influx of patients, some countries decided where possible to build new hospitals, others to reshape several departments into intensive care units, or to renovate old hospitals to become new COVID-19 centers, aiming at drastically increase the number of intensive care unit beds, as well as intensive care unit staff and life-saving ventilators and other related supply. During this critical situation in which countries are racing against time in arranging new intensive care units, the main problems of ventilator supply has emerged. This problem could be considered as two sides of the same coin. From one side, we have the manufacturers, where the high technological complexity of intensive care ventilators make the time required for their production crucial. So they experienced problems to rapidly increase the manufacture of intensive care unit ventilator to deal with the demand. And in addition, as life support devices, ventilators have to pass robust regulatory tests before they are receiving the approval and can be delivered to the hospitals. Moreover, some companies converted their production to intensive care unit ventilators. On the other side, we have the buyers. So the hospital for which the problem of resource allocation was exacerbated during this global pandemic, and it emerged that the selection of the type of the intensive care ventilator that best fit with the specific health and social context needs was based on time and available resources instead of quality, appropriateness, and effectiveness. In fact, there are several examples that are suggestive of waste of time and resources. The first example comes from UK, where ministers ordered 10,000 extra ventilators, prioritizing the production of basic devices. However, it was noted that critical cases were more complicated than expected, and for this reason, government decided to prioritize more sophisticated devices and cancel the order of thousands of units of a simple ventilator model. In the meantime, in France, the government requested the production of 10,000 ventilators, half of which were sophisticated models, while the other are more basic defined. As the former are more complex and take much more time to be manufactured, government required the production of a greater number of basic design ventilators, approving the manufacture of 8,500 basic devices and 1,600 more sophisticated devices in 50 days. Unsurprisingly, the 8,500 basic devices were considered useful only for patient transport, but not for treating critical patients in intensive care units. From these examples, it clearly emerged that the frenetic race to the increase of ventilator provision was initially not counterbalanced by the quality evaluation of these devices. So while countries were racing against time in arranging new intensive care units, and taking into account the complicated variety of ICU ventilators designs currently offered by a number of manufacturers, together with the limitations in time and resources during the emergency, stakeholders necessitate affordable solutions to rapidly understand the real needs of a specific health context. This means learning how to correctly evaluate the coherent amount of ventilators really needed in a specific context, as well as the essential technical requirements that ventilators should have to ensure effective treatment for COVID-19 critical patients. And for this reason, through this work, we aim at offering an overview of how the application of a structured and reliable evidence-based approach for technologies evaluation may provide support during COVID-19 pandemic in ICU management and critical equipment supply, and to define the essential technical requirements that an intensive care ventilator should have in order to effectively treat COVID-19 critical patients. So a general search on PubMed and Google search engines was carried out in order to retrieve as much information as possible about the indication and guidelines for the management of suspected and confirmed COVID-19 patients. The most relevant documents were gathered from the Italian Ministry of Health and from World Health Organization web pages. The two health organizations provide a detailed description of the clinical syndromes profiles associated with COVID-19 for mild, severe, and critical illnesses, and they suggested strategies to manage severe acute respiratory infection in suspected and confirmed COVID-19 patients. Here, there is an example of the clinical indication on ventilation parameters to treat COVID-19 critical patients with severe pneumonia and acute respiratory distress syndromes. Taking into account the clinical guideline, a detailed search of the publicly available indication for mechanical ventilators' essential technical requirements was carried out in order to resume and compare all the indications that the major worldwide health organizations were providing during that period. And in our analysis, we considered data from UK Medicine and Healthcare Product Regulatory Agency, World Health Organization, and CONSIP, held by the Italian Ministry of Economy and Finance. It is the purchasing center of the Italian public administration sector. And all the technical specifications and the essential technical requirements that came out during this analysis were carefully analyzed and grouped into 11 classes, including patient transport capability, internal backup battery, onboard air compressor or turbine, equipment alarms, display, monitor displayed parameters, control setting ranges, patient assessment tool, invasive and non-invasive ventilation modes, and integrated capability. And each class was then described by a number of specific and detailed indicators that have been made explicit according to the data retrieved from the three organization websites. As you can see from this table, that is the main result of our work. So taking into account the clinical guideline for suspected and confirmed COVID-19 adult and pediatric patients, even if the three organizations provided different ranges for ventilator parameters, they do not appear significantly different from each other. More specifically, while CONSIP and WHO provided indications for adult and pediatric patients, the information retrieved from UK focused only on adults. Moreover, UK proposed as essential ventilator requirements, those refer to ventilators for few-hour short-term stabilization. In fact, as you can see from this other side of the table, it emerged that the UK recommends fewer ventilation modes, excluding, for instance, assist control modes, as well as fewer alarms than WHO and CONSIP. In conclusion, we claim that incentivizing cost-effectiveness analysis and the use of evidence-based health technology assessment could lead to a reduction of unnecessary expenses, keeping the real health needs and time as driver indicators. In fact, during an emergency situation, the absolute priority is saving lives, and the way to better do that should be guided by scientific evidence. Prioritization of health needs is pivotal during emergency. emergency, and a structured decision-making processes based on evidence are able to optimize time and resources allocation, evaluating the safety and effectiveness of a given medical device, together with the effect of its introduction of a healthcare setting. Finally, in this context, the comparison among different countries' point of view might be crucial. In fact, institutions should collaborate more and more in order to provide unequivocal, reliable indication to help the world to emerge from this crisis. We strongly believe that elaborating clear indications from available scientific evidence and spreading them throughout the most renewed world institution may provide significant help in this pandemic emergency, guiding and supporting the crucial decision-making processes that are affecting the life of millions of peoples and the economic burden of all countries that are dealing with this common enemy. It is the paper published about this work, so all the details about the essential technical requirements provided by 3 health organizations and the table that contain all the information, you can refer to this paper. Is an open access and available online. And thank you for your attention.